So hello, my name is Elisa Agostinetto. I'm a medical oncologist and research fellow at Institut Jules Bordet in Brussels, Belgium. And today I would like to discuss with you the clinical case of a patient with breast cancer. So this clinical case is about Sarah, a woman of 59 years old in postmenopausal status that came to the clinic because she noticed a lump in her right breast. So at the hospital, she underwent breast imaging that showed a lesion of 30 per 20 millimeters in her right breast. A biopsy was also performed, and this confirmed a histological diagnosis of invasive breast cancer. The immunohistochemistry testing revealed expression of the estrogen receptors with an expression of 83%, and a negative HER2 expression with an immunohistochemistry score of 0. At this point, a disease staging was performed using a CT scan, and this revealed the presence of additional lesions, specifically 3 lesions in the bone, 2 lesions in her femoral bone, and 1 lesion in her scapula. At the time of the diagnosis, the patients underwent a genetic testing, but this didn't reveal any germline BRCA mutation. So basically, this is the case of a patient with a diagnosis of estrogen receptor positive, HER2 negative, de novo metastatic breast cancer. And for Sarah's initial treatment, she was prescribed a combination of letrozole plus ribociclib. As we know, indeed, that for patients with hormone receptor positive, HER2 negative advanced breast cancer, the standard of care in first line is represented by a combination of CDK4/6 inhibitors plus endocrine therapy. So now, 22 months after Sarah's initial treatment, she's back to the hospital for her periodic disease reevaluation. And at this time, Sarah is complaining of fatigue. The CT scan performed as disease reevaluation revealed now 2 new lung lesions in her right lung and an increase in the lesions in the bone and in the breast. So now that the patient is experiencing a disease progression, her physician would like to check for possible actionable target to choose the best treatment strategy. What would you recommend at this point? A tissue biopsy or a liquid biopsy? So in this context, liquid biopsy is definitely a good strategy for test for possible targetable mutations. Indeed, we know that also according to guidelines for patients with hormone receptor positive, HER2 negative advanced breast cancer, a liquid biopsy is recommended to test for possible actionable targets like ESR1 mutation or PIK3CA mutations. And specifically for ESR1 mutations, the liquid biopsy is the best strategy to test these type of mutations. Indeed, ESR1 mutations are often subclonal mutations, and that the liquid biopsy has a higher sensitivity compared to a tissue biopsy to detect these type of mutations. This is different from what concerns, for instance, PIK3CA mutations that are more often clonal mutations, meaning that they can be tested both in a liquid biopsy or in a tissue biopsy. But for ESR1, the liquid biopsy is the best strategy to test this type of mutations. So coming back to our clinical case, to see the results of the liquid biopsy that was performed in the context of this clinical case. So the test has now identified an ESR1 mutation. No other mutations were identified. Which therapy would you suggest moving forward with? So concerning elacestrant, this is the first oral SERD that was approved by the FDA for the treatment of patients with hormone receptor positive, HER2 negative advanced breast cancer with an ESR1 mutations who has already received at least 1 line of endocrine therapy for the metastatic setting. You can see the study design of the Emerald trial, whose results led to the approval of elacestrant. And you can see also the Kaplan-Meier curves showing improvement in progression-free survival associated with elacestrant, and the curves of an exploratory analysis showing that the longer the duration of the prior treatment with CDK4/6 inhibitors, the longer the benefit from elacestrant in subsequent lines. So the physician has now chosen elacestrant as second-line treatment for our patient. And as such, which adverse events can we expect more commonly with this treatment? So concerning nausea, vomiting, and fatigue, indeed, these were among the most common adverse events that were observed among patients treated with elacestrant in the Emerald trial. And you can see the table with the most common adverse events observed in this clinical trial. And interestingly, nausea, that was the most common adverse event occurring in 35% of patients, was in most cases a low-grade nausea, grade 1 or grade 2, with a grade 3 occurring in only 2.5% of patients. There are other SERDs that are nowadays under clinical investigations. You can find out more information about it. So in conclusion, I hope you found this clinical case informative. And to summarize, we can say that the patients with disease progression following CDK4/6 inhibitors plus endocrine therapy for advanced breast cancer have several therapeutic options. And in case of a detectable ESR1 mutation, these options, of course, include elacestrant. Liquid biopsy is the preferred method for detecting ESR1 mutations, thanks to the higher sensitivity compared to a tissue biopsy. Elacestrant was the first oral SERD to be FDA approved in January 2023 for patients in postmenopausal status with ESR1 mutated, estrogen receptor positive, HER2 negative advanced or metastatic breast cancer with disease progression following at least one line of endocrine therapy. And elacestrant has a manageable safety profile consistent with other endocrine therapies. So I hope you found this clinical case interesting and informative. Thanks again, and see you soon.